Good afternoon, everyone. Thank you for joining us today. This is part of our RHC webinar series. Jonathan will be presenting over how primary care and hospital operations can work together. This is a pretty timely and great topic. I was just going through all of our rural health clinics yesterday. I think we're at about like 131, and of those, 75% are provider-based here in the state. And so this is a pretty good topic for most people on the call. If you are watching this recording, if you have questions, please feel free to reach out. If you're on the call live today, if you have any questions, please put them in the chat. I'll be watching, or you can unmute your lines. And with that said, Jonathan, I'll turn it over to you.
Thanks, Laura. So excited to present on this topic today. Now, again, as Laura mentioned, this is being recorded. In addition to that, the slides will be made available after this presentation. So again, whether you have questions today or you have them at a later date, please don't hesitate to reach out, whether it's to Laura or me or somebody else. Again, we want to ensure you get accurate information around all of these different topics. Now, what we're going to talk to today is really how primary care and hospital operations can work together. Now, this could mean 1,000 different things, and it can go in many different directions. Now, when we talk about with the primary care and we talk about hospital operations, primary care is growing in importance. Again, it very much is the entry point to most healthcare within the environment in which we operate. Again, oftentimes patients go and see their primary care providers, or they have their regularly occurring visits. Now, what are the different ways that primary care and hospital operations can work together? Now, beyond just the actual delivering of services, there's also different administrative ways, there's operational ways, and there's different ways that we can leverage the different types of entities or the business units as a way to improve healthcare going forward. Now, one thing is for sure, we have to start looking at primary care and hospital operations and the total continuum of healthcare as a whole if we want to truly start to drive the healthcare industry towards patient outcomes and population health, and really driving community outcomes at that level. Now, again, so long as we consider primary care as either a distant service, not really directly involved with hospital operations and those broader hospital services, we will continue to see a segmenting across the industry. Now, when we look across the industry also, those organizations that have truly integrated primary care into that delivery model have improved outcomes, they have better response times, and they have better satisfaction with their patients as a whole. In addition to that, they've also been able to control the cost of healthcare within their environment. Now, when we think about it to that degree, again, primary care is one of the most cost-effective ways that we can actually provide care to our patients. Anytime a patient goes to the emergency room or has an inpatient admission, or if they don't get those primary care services and they continue to have negative outcomes, they will lead to surgical procedures and all of those things to that level. Again, all of these things are different ways that will cost the healthcare environment more over time. Now, what are we going to talk about today? Now, when I talk about the different types of primary care integration, one thing I want to emphasize is there is no one-size-fits-all for every healthcare entity. In some environments, you may need only a single practice. In some environments, you may need a multi-specialty practice that looks at the integration of primary care and specialty services. What we have to start doing is we have to take a step back and evaluate the services that we actually need within our community and start to make decisions based on the demand for those services. Now, to take that a step further, when I talk about the service demand within our community, what we also have to do is we have to catalog the number of providers that are providing services currently within our community. Again, just because we do not have a primary care provider does not mean there is an oversaturation of those services already in our industry. So we have to start looking at those things going forward. What we also have to realize too is that when we talk about the designation of those practices, again, same with the service delivery, there is no one size fits all for designations. Now, I've seen FQHCs be most advantageous. I've seen provider-based clinics. I've seen rural health clinics. Again, it's selecting what you can do regulatorily, what you can actually meet from a designation requirement approach, and how we can look at establishing those things going forward. Now, the last of those clinic designations, again, is that freestanding health clinic. Now, again, when we operate in an environment, if we can't operate under one of those other designations, again, we may want to establish that as a freestanding health clinic so that we have that integrated within that broader healthcare environment. Now, one thing that is also important to mention too is when we think about that broader healthcare environment, as we start to integrate different services and we start to integrate those up, whether it's under a hospital, whether it's in a multi-specialty practice, we start to be able to leverage economies of scale. Whether we can leverage GPOs, whether we can leverage shared administrative staff, all of those are additional ways that we can look at leveraging opportunities and starting to look at that integration. In addition to that, what I'm also going to talk about is reimbursement trends and strategic opportunities. Now, again, when we start looking at integrating primary care into hospital operations, it's not only the direct services that those primary care providers can provide, it's also all of the downstream services that that hospital can look at incorporating or gaining by starting to partner with primary care. Again, there may be diagnostic imaging follow-up, there may be rehab services, specialty services, surgical services. All of those can come out of primary care. Now, what we're realizing also in today's times is primary care is growing in importance. Again, as I mentioned earlier, it is that access point to much of the healthcare services patients will receive going forward. We have to start to integrate and realize the benefit that that primary care provides and how we can look at those leveraged opportunities going forward. We're also going to talk about some reimbursement trends and strategic options. Again, depending upon the type of designation we have and how we're looking at integrating those services, will ultimately dictate what is the most advantageous reimbursement. Now, again, depending upon the practice, the cost structure, the type of services, the volume of services, all of those will have a direct impact on the financial performance going forward. We have to realize that, again, just because something does not make sense as a freestanding clinic does not mean it does not make sense as a rural health clinic or an FQHC or a provider-based clinic. We have to look at what we can establish and how we can look at integrating things going forward. And then the last area we're going to focus on is really looking at some of those different integration opportunities. Now, oftentimes, many people think about those chronic care conditions or different things of outcomes or pushing patients to swing bed services or post-admission follow-up, again, or post-discharge follow-up. All of those are additional ways that we can partner together. How can we start looking at integrating those services going forward and working together to, again, reduce that financial burden on the patient, but also improve outcomes for the patients across the board? Now, I know I've presented on this before. When we talk about the rural environment, it's important to note the rural environment is a unique situation that all of us have to start to encapsulate into our broader strategies. Now, rural providers experience barriers that are oftentimes not experienced in larger situations, whether it's large urban settings or multi-institution or multi-entities that are part of a same healthcare entity. Oftentimes in rural, we see a highly fragmented provider area. Again, oftentimes providers in primary care are not speaking to hospitals. They're not integrated with physical therapy. They're not integrated with specialty services. So what we have to realize is because of the fragmentation within that rural environment, we oftentimes have patients that have more negative outcomes or lost to follow-up, or they're not able to get the appropriate services. In addition to that, we also have to realize that there is an entrenched need for autonomy and oftentimes cultural resistance within many rural communities. In fact, I was talking to a hospital this morning that operates some rural health clinics, and we were having conversations around some of their providers. Now, some of their providers had been there for 20 years. And the problem was as they were trying to modernize and move things, whether it's towards work RVUs or working towards certain patient outcomes, the providers were very much still in the mindset of this is the way we've always done things, and you need me more than I need you as an environment. Again, we have to realize that as we continue to move forward, we have to look at integrating, again, primary care into that broader environment. And we also have to realize that there is a lot of arcane and complex environments around regulations and laws applicable to those rural markets, particularly for hospitals, whether you're a critical access hospital or a sole community hospital operating a rural health clinic or a freestanding clinic. How we operate and integrate that has a direct impact on reimbursements and how we can leverage those opportunities going forward. Again, we cannot look at this as a one-size-fits-all approach. Now, what is also important to mention too is that there's different levels of integration of primary care within a hospital environment. Just because a hospital maybe owns a clinic does not mean that clinic is actually integrated into the hospital operations or a broader part of that entity as a whole. I've talked to many organizations where this is a critical access hospital that owns the RHC. And even though the RHC is owned by the critical access hospital on paper, and on paper it rolls up organizationally on the organizational chart, it still broadly operates as a separate unit. Again, the providers are doing their own thing. They're not a part of the broader performance improvement at the hospital. So when we look at truly integrating primary care with hospital operations, we have to realize that there are those different levels of integration. We have to continue to work forward and integrate primary care across that full continuum of the hospital operations. Again, they have to be a part of performance improvement initiatives. They have to be a part of the revenue cycle processes. They have to follow MEC and all of these other administrative processes that are instituted across that organization. We will not improve or we will not be effective in our environment if we only look at integrating primary care to the level of just owning and operating primary care practices. We have to take it that step further. Now, when we talk about integrating primary care and hospital operations, it's important to note, particularly in rural communities, there are specific financial incentives or advantages to integrating primary care into a hospital, such as a critical access hospital. Again, there's reimbursement advantages. There's the ability to qualify for, say, 340B. There's the ability to go after additional revenue streams as a way to improve the financial position of both entities. In addition to that, there's also, as I mentioned earlier, the economies of scale. As we start to integrate, we get access to a CFO, maybe quality directors, maybe additional support staff. We can flex staffing. We have the ability to integrate those services and start to supplement the ability to provide care within our community. Again, we want to look at all of those different opportunities. Now, when we talk about those different opportunities and how we can integrate primary care, it really spans across a couple key areas. We have the financial incentives, we have the service delivery opportunities, we have the administrative benefits, and then we also have the quality improvement area. All of those are equally important as to how we can start to drive processes and performance improvement within that clinic and to start to improve patient outcomes going forward. Now, one thing I want to emphasize before we start jumping into some of the additional information is a key concept that has come up in recent years. Again, it's always been out there, which is our Medicare Economic Index. Now, particularly for our rural health clinics, again, I know this is an RHC-based presentation today, we have to pay particular attention to the Medicare Economic Index going forward. It doesn't matter whether we are a grandfathered RHC or an independent RHC, or an RHC owned and operated by a hospital with 800 beds. Going forward, at some point, all RHCs will be subject to an increase based on the Medicare Economic Index. Now, why is this important? The reason why this is important is as we start to look at integrating our rural health clinics with hospital operations, again, whether it's a partnership or going to full acquisition, we have to understand the cost structure of how that plays out on our clinics going forward. Now, if we look at the average over the past 10 years, we can see the Medicare Economic Index has gone up by an average of 1.6%. And if we look back over those years, only in 2023, this current year, was there an increase anywhere near what the cost increase has been experienced by our clinics within those markets. Again, that was 3.8%. Now, when we look at our clinics going forward and we look at the fact that there is going to be cost increases that are going to continue to outpace that Medicare Economic Index, we have to look at different ways to drive volume going forward. Again, volume is going to be the solver for many of our issues. As we increase volume, we are going to dilute down the cost per unit of service going forward, which can allow us to stay under that upper payment limit. If we are not able to drive volume to our clinic, how many of us are able to keep our costs below 2%, 1.9%, or even 3.8%? So what are we looking at with our providers? Now, when we look at integrating primary care into hospital operations, let's say we're an independent practice right now, and we were to look at integrating within a hospital entity. Now, when we look at it to that degree, again, we may have separate rev cycle, we may have a practice manager, we may have certain support staff. Again, those are all areas where there may be duplication that by integrating with a hospital, we could start to look at things to that degree by cutting some of the cost. Inside those rural health clinics, I will emphasize it is extremely hard to cut the cost of our providers and our direct patient care staff because oftentimes many of our clinics are either operating at minimum standards or they are near that minimum productivity threshold. So again, we have to look at opportunities to potentially control cost in other ways. Integrating with the hospital is a way that we can start looking at those things. Again, because we will be able to pull down proportional cost to that RHC based on the proportion of that RHC to the broader hospital itself. But it's key, again, we have to look at the Medicare Economic Index and we have to continue to take that into account as we look at things going forward. Now, when we talk about performance improvement, and here's an area when we integrate RHCs into hospital operations, performance improvement is an area where we can actually start to push the needle and drive outcomes for our patients. Oftentimes, if you are an independent RHC, or even if you're integrated within a hospital, but you continue to operate as really an owned entity, but a distinct unit, a lot of times you're not truly focusing on broader performance improvement initiatives. What we have to look at is we have to look at both the financial and the quality implications of our organization and start to realize how we can start to drive performance improvement. Again, when we look at the quality side, it's patient outcomes, it's driving things to that degree. On the financial side, it's starting to push towards actually driving an improvement of the bottom line. Now, if we were to go back 20 years ago, I would say finance drove many of the decisions. Again, there wasn't really a push towards PCMH and population-based outcomes and quality incentives to that degree. In today's times, quality has a direct impact on our financial performance, and our financial performance has a direct impact on what we can afford to do from a quality and clinical perspective. Again, we have to start to realize the interrelation and start to integrate within those broader performance improvement initiatives. Only then can we truly start to drive the needle and move things forward. Now, how did we get to where we are? Now, when we talk about the evolution of improvement models, and again, if we go back to the 80s, it was really segmented. The healthcare industry is one of the most segmented industries out there. When we went back to the 80s, we had quality insurance, we have revenue cycle, and we had finance. And each one of those really did separate things. Again, they stayed within their lanes, and there wasn't a lot of cross-pollination across the different areas of looking at how we can drive things going forward. There wasn't much change. Through the 90s, quality assurance changed to quality improvement, revenue cycle was still revenue cycle, and finance was finance. It wasn't until we got to the year 2000 that we really saw our first major merging of two of those functional areas. And we saw revenue cycle and finance really start to come together broadly across the industry because we realized that revenue cycle had a direct impact on financial performance. Again, if we weren't getting patient insurance information, if we weren't checking their ages, their names, all of that stuff, we were starting to see an increase in denials and we were starting to see a negative outcome in financial performance. But again, quality was still very much segmented. In today's times, we have to realize that our top performing organizations are those that have truly merged quality and finance into a single performance improvement collective. Only those organizations have really started to drive the needle in that area. Now, to bring this back to the integration of primary care, oftentimes when we think about hospital operations, we think about the emergency room, diagnostic imaging, rehab, lab. We think about our inpatient unit. Have we started to look at how we can truly integrate primary care into that broader approach? Now, what I mean by that is let's take a swing bed patient and we look at performance improvement in that area. How often does a patient get discharged from a swing bed program that they won't have some type of follow-up going forward in looking at those different areas? Again, oftentimes a patient will be discharged from a swing bed program. They either need rehab follow-up or we're going to want some type of transitional care management post-discharge with that patient. This is a way that we can start to pull primary care into those conversations and to start to improve patient outcomes. Again, have we created the linkages that will actually allow for a seamless process for our patients? Or are we still requiring many of our patients to actually figure out the process themselves? These are ways that we can continue to move the needle going forward. These are ways that we can start to integrate those areas. In addition to that, as we're talking about evidence-based outcomes, are our providers within our rural health clinics or in a primary care setting, are they a part of the broader medical executive committee? Are they integrated into that area? Are you having conversations about the full delineation of privileges and all of those additional things that is inclusive of primary care? Or are you very much segmenting those things out? Now, again, depending upon whether we are, a joint commission hospital or whether or not we are surveyed by the compliance team or how we're looking at those different areas, we have to meet different levels of integration if we are owned and operated by a hospital. But again, when we look at those bare minimum requirements, these are not the requirements that are establishing the top performing organizations. As we look at those core requirements, that should be very much a foundational approach. We have to continue to push forward as a way to drive that further integration of primary care going forward. Now, before we get into some of those distinct advantages and integration opportunities, I always like to spend a few minutes on understanding your cost structure. Now, the reason why I'm bringing this up, particularly for something relative to the integration of primary care and hospital operations, is because within our rural health clinics, we have a certain amount of fixed cost. Again, upwards of 90% of our cost is fixed. We cannot get rid of that cost within that environment. So as a rural health clinic, we can really only control upwards of 10% of our cost within a given year. All of that other cost is fixed, whether we have 1,000 patient visits or 3,000 patient visits. So what we have to realize within that environment is, again, we cannot cut our way to success within that environment. We have to start looking at different ways that we can increase volume within our clinics. Now, when we realize that environment within our clinic and we operate within that environment, let's take, for example, go back to that swing bed example. Have we created that environment where our primary care providers, and again, it doesn't matter whether you're an independent rural health clinic or you are a provider-based rural health clinic owned and operated by the hospital. As a rural health clinic and your providers, have you created the linkages with that hospital so that as soon as one of your patients gets discharged, you have access to the appropriate information, you can follow up with that patient, you can ensure that they are improving their outcomes going forward? Or again, are we leaving our patients to have to fend for themselves going forward? This is a way that we can, again, increase volume within our clinic. It's a way that we can drive outcomes. It's a way that we can actually improve patient satisfaction going forward. As we look at that clinic, though, again, we cannot cut our way to success as a rural health clinic. You will always have an inherent amount of fixed cost going forward. Now, when we talk about that economic philosophy, and it doesn't matter whether this is a critical access hospital or a rural health clinic, we have a certain point that we have that fixed cost, and again, we have that variable cost. Just by opening our doors on any given day, we automatically start at a loss. Again, so if we start on January 1st of this year, that's the start of our fiscal year, we're incurring all of this expense, regardless of whether or not we get those patients. As we continue to increase volume, we will eventually move from a loss position to a profit position. And you'll notice that there's really two inflection points on this picture up here on this graph. When we look at it going forward, we can see that the first inflection point is past our fixed cost. That is that first key requirement. If we don't generate enough revenue to at least cover our fixed cost, we are going to be in a tough position going forward. The second inflection point is really covering our variable costs in addition to the fixed cost. Once we pass that point, we will ultimately get into a profit position. Now, one thing I want to emphasize, particularly for everybody on the webinar today, because we are rural health clinics, what I want to emphasize is that we cannot make a profit or we cannot be a profitable entity if our Medicare reimbursement rate is higher than what we receive from commercial and other payers. Because the best that we can do for Medicare is cost-based reimbursement for those services. So long as our Medicare rate is higher than our commercial rates, we will have to make up that margin elsewhere, whether it's 340B, whether it's negotiating a PMPM with commercial payers for doing population-based initiatives, whether it's PCMH or other things. What we have to do to truly be financially solvent as an entity, as a rural health clinic, we have to drive volumes up to the point that we dilute down our Medicare cost per unit of service to where it's less than what we're receiving for commercial. Once we get to a point where our commercial rates and other payers is higher than what we receive from Medicare, we can start to turn a profit as a rural health clinic. But it's important to note also, if we are a hospital-based or an independent rural health clinic, it doesn't matter. What we have to look at is we have to look at our fully allocated cost. Again, if we're owned by a hospital, we're going to step down a bunch of administrative overhead. If we're independent, we're not going to have a bunch of administrative overhead stepping down, but we're still going to have a bunch of expense that's not directly related to patient care. We have to look at our fully allocated cost and use that as the basis to determine whether or not we are profitable as an RHC going forward. Now, the next area we're going to focus on, and again, it's very much the framework for what's driven a lot of these population-based initiatives. Now, I realize in today's point, there's also the quadruple aim, but for today's purposes, I'm really going to talk about the triple aim. Now, the triple aim really focuses on three priority areas: it's population health, experience of care, and per capita cost. Now, the real goal of the triple aim was to improve patient outcomes, improve the health of broader populations, and reduce the per capita cost of healthcare. Now, I fully agree that there's no way that we can sustain long-term the cost of healthcare within this country. Again, the cost continues to outpace reimbursements received. At some point, we're going to have to look at different ways that we can start to drive down the cost of care. Now, when we start looking at driving down the cost of care, again, focusing more on patient outcomes is one of the ways that we can start to drive down the cost of care. Again, we want to focus on individuals. We want to look at population health management. We want to look at cost control. Now, if primary care continues to operate as a distinct separate segment away from hospital operations, how can we truly start to improve health outcomes for our patient populations? Again, most of the expense in healthcare is on surgical procedures, inpatient admissions, all of that stuff. It's not in primary care. So what we have to start looking at is integrating primary care to start getting more touches with our patients, to get them in more frequently, to try to address the chronic care conditions, to try to catch things earlier so that it doesn't lead to an emergent situation or an inpatient stay or so forth. Those are different ways that we can start to improve patient outcomes and truly start to drive down the cost of healthcare within many of these rural markets. So practice designations. Now, when we talk about the integration of primary care, and again, I know this is predominantly focused on RHCs today, I'm going to spend a few minutes on the different practice designations. The reason I'm spending a few minutes on this is because, again, as we start looking at integrating primary care into hospital operations, I don't want to assume that the RHC designation is the end-all be-all and the best designation for every entity out there. We have to constantly continue to evaluate what is the optimal designation for our practices so that we can look at, is it in the best position financially? That may be an FQHC. It may be an RHC that's independent. It may be an RHC that becomes provider-based. It may be a provider-based clinic. We have to start to evaluate all of those different things. Now, the first one is really that federally qualified health center. Now, I'm sure everybody out there is aware of the FQHC. Now, the FQHC is really a specific program that was established to target and provide services to an underserved population. Now, one thing that's important to note about the FQHCs is it's not really as important where the FQHC is located. It's more important the patients that the FQHC serves. So if you were to go in for an FQHC designation, you have to identify a specific underserved population that you want to serve under your FQHC or through your FQHC. Again, completely different than the rural health clinics. When we look at FQHCs, there's generally only one FQHC within a certain regional area focused on providing services to that specific population. So again, there's not the duplication of FQHCs. Now, what are some of the benefits of FQHCs? You can receive enhanced reimbursement. The FQHC rate's approaching $170. You have the ability to participate in 340B. You have the ability to go in for the 330 grant, and you also have malpractice insurance savings. All of these are additional ways that you can look at leveraging the benefit of that FQHC as a way to provide services going forward. Now, one thing that's important to note, when we talk about our rural health clinics, for the instance that they have to be located in a rural shortage area, your FQHCs have to prove that you are serving patients from either a medically underserved area or a medically underserved population. The FQHC itself does not have to be actually located in one of those areas. You just have to prove that you serve patients from one of those areas. And I'll give you an example. There's an FQHC in actually Waikiki in Hawaii that has targeted a homeless population for an actually medically underserved population. Now, again, when we think about that, Honolulu, Hawaii is definitely not rural, and there is an abundance of providers across that county. But again, because there's an underserved population, they were able to go in for that FQHC designation. So again, it's targeting specifically a specific type of person that they want to provide those services going forward. The next is a provider-based clinic. Now, a provider-based clinic is owned and operated as a department of the hospital. Now, when we operate as a provider-based clinic, it's important to note that they have to be fully integrated within the main provider's financial system. You can't operate it as a distinct unit. You can't consolidate financial statements at a later date. They have to be on the cost report of the hospital. They have to be included. If you operate an off-campus provider-based clinic, there are different distance requirements that you have to follow. For instance, if you are a regular PPS hospital, that provider-based clinic has to be within 35 miles of the hospital that operates it. If you are a critical access hospital, that provider-based clinic has to be greater than 15 miles on secondary roads and 35 miles on primary roads from the next closest hospital that is like the hospital that owns and operates it. If you are a provider-based clinic under a critical access hospital, also, again, you could bust the CA designation if you do not meet those certain requirements. Now, it's important to note that, again, if you are a provider-based rural health clinic, you are exempt from both of those distance requirements. The next thing to emphasize also is if you are an off-campus provider-based clinic, there was something that came out years ago called site neutrality. Those off-campus practices no longer get an incentive to be a provider-based practice from Medicare owned and operated by a hospital. You get the ability to participate in 340B if the parent hospital qualifies for 340B. Again, there are different advantages to operating as a provider-based clinic. The next area, and again, hopefully everybody on here operates within and knows the rural health clinic requirements. But again, a rural health clinic is a specific designation that clinics can go for that, again, enhances reimbursement and provides certain advantages. Now, there are certain requirements to operate a rural health clinic. You have to employ an APP. You have to have a physician overseeing the practice. You have to have all of those additional requirements. It's important to note that all RHCs are subject to some form of an upper payment limit, again, going forward. Gone are the days of full uncapped cost-based reimbursement. Now, when we look at integrating those rural health clinics and how we can continue to provide services going forward, as I mentioned a moment ago, RHCs are exempt from many of the distance requirements. They're exempt from the 35-mile requirement. So that's important from the perspective that you can actually have a rural health clinic owned and operated by a hospital that's 80, 90, 100 miles away from that hospital that owns and operates it. Again, you have to meet certain integration requirements, but as long as you meet those requirements, you can operate as a part of that hospital. Again, it's exempt from our critical access hospital distance requirements. I know of several organizations across the country where a critical access hospital actually operates rural health clinics in the town or the county of a much larger hospital. Again, this is a way that you can leverage that opportunity. So what I want to emphasize with our rural health clinics is that when we look at our rural health clinics, whether we're independent, whether we're provider-based, and how we want to look at those things going forward, because we continue to operate in an environment where cost is increasing at a greater rate than reimbursements, we want to look at all of these additional ways that we can leverage these opportunities to improve financial performance. If we are in a system environment, what we have to start thinking about, particularly when we're looking at primary care and the service delivery, we have to start looking at the collective financial performance of the system and care less about the individual financial performance of each business unit. Now, what I mean by that is I've been engaged with many organizations in the past, and it's the 1980s, 90 methodology where they have a bunch of hospitals that are owned and operated by the system. Then they also have a bunch of practices that are operated as freestanding clinics, and it's a wholly owned medical group. And again, they operate that wholly owned medical group just billing fee service going forward. We have to start looking at, can we align and reevaluate our practices, and can we designate them, whether it's under a critical access hospital, sole community hospital, PPS hospital. We have to, again, stop being concerned with what the individual financial performance is of each of these different units and start looking at the individual performance of the entity as a whole. So again, if realigning our practices or integrating primary care into hospital operations or under a hospital can improve the collective net bottom line of an organization, we should be considering that going forward. We should not be continuing to operate in a status quo environment just because that's the way we've always operated, or because we want to maintain the division of units going forward. We want to look at these different opportunities. Now, I know I've presented on this many times, in addition to also with the RHC group today. What we want to look at is it's important to note that as we look forward for our rural health clinics, all RHCs, again, are subject to some form of an upper payment limit. Now, for our independent RHCs and our RHCs that are owned and operated by hospitals with 50 plus beds, you are subject to an all-inclusive rate, that national capped rate. The only thing that has changed for you is what the upper payment limit is. Again, it used to be $87 before it changed in 2021, then it went to $100, then $113 last year, it's $126 this year. It's trending forward all the way to $190 in 2028. Where the real change came was, again, for our RHCs owned and operated by hospitals with fewer than 50 beds. If you were established after 12/31/2020, you are now subject to the national limit, the same as the independents and the RHCs owned and operated by hospitals with greater than 50 beds. If you are an RHC that was established by 12/31/20, or you had submitted an application by that date, you are now subject to a capped rate based on your 2020 cost report or the first cost report filed and reconciled for that RHC. Now, it's important to note that as we look at integrating primary care going forward, we have to understand the financial ramifications of the change in the reimbursement methodology. Again, there's RHCs out there that had $500, $600 rates. I'm not saying that's sustainable going forward, but what we have to start looking at is how we can operationalize things and how we can look at cutting and controlling costs or increasing volume or expanding services as a way to drive services going forward and increase volumes. And I'll give you an example right here. So here's a way that we can actually start looking at integrating primary care into hospital operations. Now, when we have a primary care clinic that's a rural health clinic and we have a hospital, oftentimes many hospitals will operate a hospitalist program. And maybe that hospitalist program is doing all of the swing bed services, and they're also providing nursing home services. Our rural health clinics can actually provide a swing bed visit and a nursing home visit as an RHC qualifying visit. So again, this is a way that our RHCs can partner with our hospitals as a way to control cost at that hospital, but also get enhanced rates for providing the same services. Now, again, if we look at integrating into that hospital or providing services to that nursing home, we are able to increase volume at a negligible cost. But again, all of those count as primary care visits, so it could help us on our 51% also, but it's a way that we can start to integrate and reduce down that cost of care by reducing some of the duplication within that healthcare environment. If we are an RHC owned and operated by a hospital now, but we have separate providers that are doing all of the inpatient care, have we looked at integrating those providers into the RHC? Again, nursing home visits, swing bed services all count as an RHC qualifying visit. Now, again, we do have to do time studies and we have to carve out the time those providers are doing acute care services, but have we evaluated this and have we looked at the net impact? This is a perfect example of how we can start to integrate primary care in what is generally seen as a primary care practice with RHCs and hospital operations for the collective benefit of both units. Now, the last area is really around freestanding health clinics. Now, I generally like to say if you can be any designation but a freestanding health clinic, you generally want to be that designation. Again, as a freestanding health clinic, all you are billing is pro fees for the services that you're providing. You get no OPPS reimbursement if you're owned by a hospital. You get no cost-based reimbursement under a critical access hospital for the facility component. All you are able to bill is those pro fees. You also don't get the ability to participate in 340B if you're owned by a hospital. Again, the benefit of the FSHC is if you cannot be any other designation, it's oftentimes better to have that practice integrated and as a part of your business entity than it is to have some type of competing practice out there. But if we have a practice, we always want to look at whether or not we can establish it as some other designation first before continuing to operate it as an FSHC. This will improve our position down the road and actually benefit us long term. Now, what are some of those strategic advantages? And I skipped the last slide because, again, we went through a lot of those opportunities already as we were walking through each of those different designations. Now, when we talk about the integration of primary care and services, I like to say there's 4 key strategies that we really have to be looking at when determining whether or not we want to integrate primary care into hospital operations or become a part of a hospital. The first is really looking at converting eligible practices to a designation that provides the most advantageous reimbursement opportunity. If we were an independent rural health clinic, and this year we are subject to that $113 upper payment limit. Now, even if our cost structure is capped at $100 and let's just say $25, eventually that upper payment limit that we could receive from Medicare is going to outpace what it may be as an independent clinic. Integrating into that hospital may allow us to reduce some cost structure. It may also allow us to get a higher rate based on the step down through the cost report. Again, diversifying cost or diluting cost under a greater number of business units. In addition to that, it may also allow us to capture 340B and other things to that degree. So again, look at this as an opportunity to say, do we have the most advantageous designation for our practices? The next is looking at the realignment of practices. Again, we may have a primary care that's entity, whether it's a physician group or whether it's some wholly owned physician practice, operating as a separate business unit within that entity. We have to start to look at the realignment of practices across that entity as a way to drive reimbursements going forward. Again, if we have 20 practices that's a wholly owned physician group and all we're billing is fee-for-service revenue, how much money are we potentially leaving on the table if we could capture 340B? How much money are we leaving on the table if we could capture and operate them as a provider-based clinic or a rural health clinic? Again, we have to look at all of these opportunities as a way to capture revenue for the services that we're providing. Now, predominantly today, we're also talking about the integration of primary care into hospital operations. What we also have to realize too is that primary care is just one of the many segments within the healthcare industry. We also have to start looking at the integration of specialty services, not only into primary care, but also within hospital operations also. Let's say we're an independent rural health clinic. Now, if we were to go back a couple of years ago as a rural health clinic and we were looking at that $87 rate, it was hard to bring in a specialist. Again, specialists often have much higher cost structures than our primary care providers. It was hard to bring in that specialist at that $87 rate. Even for our independent practices, with our cost upper payment limit going to $190, we now have the ability to bring in specialty providers, whether it's dermatology, orthopedic surgery, general surgeons. Again, do we have a demand within our community? If we have a demand, we can start to look at integrating those services into our RHCs. It's a way that we can expand the service delivery within our market. Now, also, when we look at that, again, it also leverages the ability, if we were to integrate those specialty providers, say, into an RHC, it also expands the access that our hospitals have to those specialty providers. It can help us on the inpatient side. It can help us in emergency services. It can even help us with doing surgical procedures at our facility. So again, Look at it across the collective of all as a way to drive things going forward. And then the last area is really around the acquisition of independent practices. Again, are there ways that we can acquire independent practices as a way to drive reimbursements going forward? Again, now this is not to say it's automatically going to improve our net position. We may acquire a practice for strategic implications, again, because we want to integrate primary care into that broader organization. But we have to look at all of those different opportunities going forward. The key is looking at the linkages across the healthcare environment and realizing that primary care is just as important as all of the hospital operations in the full continuum of care. We can no longer continue to operate with them all as separate entities or units going forward. I'm going to give a couple examples now, just looking at different ways that the impact, again, because we're talking about the integration of primary care and financial impacts, I want to show you that how we integrate primary care and how we integrate these practices with hospital operations, there can be material differences in the reimbursements and the net financial impact. Now, up on the screen now, we can see a provider-based clinic. This was an entity that we ended up working with, and they wanted to look at integrating some provider-based clinics and establishing them as rural health clinics under a hospital. Now, this was a hospital that was greater than 50 beds. So again, if they were to convert those practices to provider-based clinics with greater than 50 beds, we could see they would have lost about $1.4 million after the provider-based clinic and after the site-neutral payment policy perspective. If we were to drop the number of beds to fewer than 50 and look at it at the OPPS site-neutral payment policy, we can see they would have gained about $1.4 million. So just the difference back in the day between a greater than 50 bed and a fewer than 50 bed was a $2.8 million swing between those different types. Again, this is a material dollar figure. Now, again, if these practices were to convert after the RHC, the Consolidated Appropriations Act, this practice would have lost $250,000. Again, there is no one size fits all. Before you make any decision, it's important to note that you have to look at the different ramifications on the different practices. Now, here's an FSHC that was looking at converting to a rural health clinic. Now, again, this was an FSHC with about 8,500 Medicare and Medicaid visits. They also had a significant number of commercial visits. Now, before they were receiving an average reimbursement of about $95 a visit. Now, again, before the change, their reimbursement rate would have gone up significantly for Medicaid. It wouldn't have gone that much up. It actually would have dropped for Medicare. They would have gained about $6,800 in reimbursement. Post the Consolidated Appropriations Act, again, because their cost structure was higher than $113, they would have received $113 from Medicare, $107 from Medicaid, they would have gained $129,000. Now, the reason why I'm showing this is because I do realize there are independent practices also on the webinar today. And it's important to note the reason why I'm showing this is because that change in that reimbursement rate, it will fundamentally change, again, how we can start providing services going forward. We can now potentially bring in that quality care manager. We can bring in certain support staff. We can leverage the gains that we're now getting going forward as a way to either expand access to care, expand service delivery, or look at different ways that we can start integrating, again, throughout that full healthcare environment. This one looks at a practice realignment. And again, when we look at this, these were multiple freestanding health clinics. They were owned and operated under a system environment. If we established them under a short-term acute care facility, they would have gained about $4.2 million. If we put them under a critical access hospital, we would have gained about $5.7 million. If we were to convert them under a critical access hospital post the Consolidated Appropriations Act, that $5.7 million gain would have dropped to $1.3 million. And it's important to note the entire benefit was attributed to 340B. Now, the reason why I'm emphasizing that also is because many of you that are owned and operated by hospitals and participating in 340B now probably have seen 340B revenues get chopped down or cut over the past several years. Again, pharmaceutical manufacturers continue to take additional steps as a way to reduce the amount of money they're paying or losing because of the 340B program. So again, we cannot do this in a vacuum, and we have to look at all of these as different opportunities. This one looks at specialty integration. Again, This was an organization that was operating a freestanding health clinic as a specialty practice and a provider-based rural health clinic. Integrating that specialty practice into that RHC, they were actually located in two adjacent suites. Integrating that into the RHC would have improved the position by about $37,000. So again, we have to start thinking outside the box. And then the last area was really looking at acquiring an independent FSHC and operating it as an RHC under a critical access hospital. Now, in this environment, again, if this was before the Consolidated Appropriations Act, acquiring that practice would have led to about a $261,000 gain for the combined entities. Post-Consolidated Appropriations Act, it would have only been about a $27,000 gain. Again, this is something that substantively impacted reimbursements going forward and how we will continue to perform. So what I want to emphasize is, again, we have to start looking at the operational configurations and parameters as to how we can start to look at integrating things and reducing cost and increasing volumes. Now, to wrap up, we're going to talk about some of those different integration operations or operational considerations. Now, one of the first things that we can look at when we're starting to focus on integrating primary care into hospital operations is truly starting to think about a clinically integrated network. Again, are we focused on team-based care? Are we focused on a collective quality improvement initiative? Have we looked at all of those different areas as a way to drive performance improvement going forward? Again, realizing that there are ways that we can have cost containment and control by looking at leveraging those opportunities and looking at ways to reduce unnecessary administrative burden and unnecessary administrative cost. We can also look at the organizational components. Again, clinical leadership, performance improvement, IT, legal and contracting. All of these are additional ways that we can leverage, again, the economies of scale as a way to drive performance improvement and drive the collective outcomes. It is very hard for a freestanding rural health clinic, an independent rural health clinic, or even an RHC that's owned and operated by a hospital, but continues to operate almost as a distinct unit, to fully perform effectively and efficiently in all of these additional areas if we're not looking at leveraging the economies of scale. We have to start to incorporate that into these things going forward. We also have to look at the referral processes. Again, realizing that oftentimes primary care is going to refer to specialty, and as patients get out of either emergency services or swing bed services or inpatient services, they're going to go back to primary care. We have to start to look at those linkages, and we have to look at the downstream revenue attributed potentially to primary care as we start to evaluate those services going forward. We cannot evaluate just the net impact of primary care itself. We have to look at all of that downstream revenue attributed to that going forward. We also have to look at all the cost savings when we're truly evaluating those services going forward. We also have to look at integrated care initiatives. Again, have we established evidence-based outcomes? Have we started looking at the delineation of services across our patient population by looking at all of the service providers we have under our umbrella? Again, looking at all of those additional areas. We have to ensure it's patient-centered, and we have to ensure that the outcomes and satisfaction plays into how we are actually making decisions going forward. Again, we cannot operate in different vacuums where primary care is doing primary care stuff and hospital operations is doing only emergency services and things. There are direct linkages, and there are ways that we can drive performance improvement going forward. The next areas that we can really focus on, and it's really across all of those care management services, and whether it's chronic care management, transitional care management, COCM, BHI, all of those additional areas, the whole alphabet soup of care management services, these are all additional ways that we can start to look at leveraging providers across the full spectrum of healthcare as a way to start to drive patient improvement and patient outcomes. Transitional care management is something that we can directly work on with our hospitals and primary care as a way to start to drive things going forward. Again, dealing with patient outcomes, it's also something that can drive revenue for our rural health clinics. Talked about chronic care management, whether it's principal care management. Again, all of these are additional ways. Now, in addition to that, what we can also start looking at too within our rural health clinics is, can we actually expand and start leveraging behavioral health services? Now, today, we've talked predominantly around primary care integration and hospital operations. We also have to realize that behavioral and mental health services also needs to start being integrated into that broad spectrum of the healthcare environment. we can no longer continue to operate with behavioral health services as a separate component. This is a way that we can start to break down those silos and barriers as a way to drive things going forward. Now, the last area is again on a patient-centered medical home. Now, again, this is not to say we need to actually go out and become certified as a PCMH, or we need to look at that to that degree. What it's really saying is when we look at these different areas, we want to start looking at how can we integrate these services and how can we start to operationalize the PCMH concepts as a way to drive performance and patient outcomes. As we start to look at the total cost or the total episodic cost of care for patients, it's when we start to realize that integrating primary care and hospital operations will allow us to start to reduce that overall cost of care. Now, one thing I also want to emphasize too is just because we integrate primary care and hospital operations and we all roll up under an ACO, what we have to start realizing again is even though primary care is not the biggest driver of revenue right now, if we look where Medicare and a lot of these ACOs are going, primary care is very much going to be in the driver's seat down the road. Again, primary care is really what's that access point or that entry point to the healthcare environment. We have to start focusing on how we can operationalize primary care and hospital operations, realizing the direct linkages and realizing that we can realize cost savings and cost containment and performance improvement by starting to focus on the linkages across those two areas. So I'm going to pause now. I know we have a few minutes left today in the presentation. Again, I really wanted to cover this at a high level and get into specific examples and really start to frame the questions and conversation around, have we truly and effectively started to integrate primary care into the broader hospital operations, realizing that there are those direct linkages, realizing that they do play off one another.
Jonathan, I'm not seeing anything come through the chat just yet. If you guys think of a question after this call, please feel free to reach out, or if you're watching this recording and you have any questions, please feel free to reach out as well. Jonathan, thank you for your time, and everyone, thank you for joining us today. We will get this recording uploaded to YouTube. Once it's uploaded, I will send out the link along with the slides, as well as registration for our August meeting, which I believe will be August 15th. Please also, one other thing, our RHC stakeholder assessment is open. Please take time to complete that because that really helps tell us what we can do to help. What are the areas that you need help in, and helps us plan out our grant activities and kind of prioritize what we work on. So if you have any questions, please feel free to reach out to me, but that will be open until I think July 21st. So thank you all for your time, and thank you, Jonathan, as well.
Thank you.